Yes. We're live in 5, 4, 3, 2, 1.
Good evening, everyone. We welcome you all to OrthoTv online. This is a masterclass on NPWT, that is optimal and efficient use in orthopedics of a very commonly known as V.A.C. This is an academic initiative brought to us by 3M KCI. To introduce today's program and the speaker, I hand over to Deepika Mehta.
Good evening, everyone. Once again, welcome to the masterclass on negative pressure wound therapy, optimal and efficient use in orthopedics. I am Deepika Mehta from 3M, and I'll be your host today. Before we get started, I'd like to share some housekeeping information with you all. There would be a live Q&A after the masterclass. To ask a question, you can forward the same in the mobile number provided in the chat box. We will try and answer as many questions as we can at the end of the webinar. Right after the webinar is completed, we'll share the link or the QR code for your feedback in the chat box, YouTube description, comment box on Facebook, and below the video on OrthoTv website. Please take out a few minutes to share your feedback so that we can improvise on our education and training services going forward. Now, it's my pleasure to introduce our faculty for today. Our first faculty for today is Dr. Vikas Agashe. He's the consultant orthopedic surgeon at PD Hinduja Hospital and Research Center and Dr. Agashe's Maternity and Surgical Nursing Home, Mumbai. He has more than 40 years of surgical experience. He's the past chairman, trauma committee, and current advisor to infection committee of Indian Orthopaedic Association. He was also the past president and vice president of Bombay Orthopaedic Society. He has been faculty at many national and international conferences since 1999. Our next faculty for today is Dr. R.M. Chandak. He's the managing director and senior consultant orthopedic surgeon at Chandak Nursing Home since July 1989. And he's also a postgraduate teacher at Radhakrishna Hospital, Nagpur. He regularly conducts surgical observership programs and workshops. He's also given guest lectures at various national and international forums and has more than 10 publications to his name. The next faculty for today is Dr. Warid Altaf. He's the consultant trauma, hand, limb construction, and microvascular surgeon associated with Sancheti Hospital in Pune. He has completed fellowship in hand surgery and brachial plexus peripheral nerve surgery at the prestigious Ganga Hospital, Coimbatore. He has published various papers in the reputed state and national journals. I would now like to call upon Dr. Vikas Agashe for his talk. Over to you, sir.
Sir, you are muted.
Hello, everyone. Welcome to this masterclass on negative pressure wound therapy. We all know that whenever we are dealing with very difficult, challenging wounds, the first step is debridement. But we need to optimize that wound before we can close the wound and do various orthopedic reconstructive procedures. Now, all these procedures often increase the chances of wound breakdown. Now, can we have something which will improve wound optimization, cover and prevent wound breakdown or recurrence during orthopedic procedures. And V.A.C. actually fills this gap. And with V.A.C., we have had several cases where wound optimization has improved significantly so that orthopedic procedures could be done safely and breakdown of the wound prevented. For any technology, it is very, very important that the technology or the method is used appropriately and optimally. It's my pleasure to invite Dr. Warid to start the proceedings with use of negative pressure wound therapy in open fractures. Dr. Warid, please.
Yeah. Thank you very much, Dr. Agashe, and thank you very much 3M and KCI for giving this opportunity to talk on this particular topic. So I'll be talking on negative pressure wound therapy in open injuries, which we have divided into two, which is like open fractures and degloving injuries per se. So the learning objectives from this talk should be the use of negative pressure wound therapy in different scenarios, which we see regularly in our practice. The challenges of negative pressure wound therapy when there is an external fixator in situ, because most of the times when we are dealing with such injuries, we need an external fixator to stabilize the limb, and subsequently with the presence of a fixator, we have to apply a negative pressure wound therapy. So we have recently seen many a times use of negative pressure wound therapy over the skin grafted areas. We will talk about that. And can the negative pressure wound therapy be exposed over a bone? Because that is also a frequently asked question in all the conferences and seminars, that can it be put over an exposed bone directly? So we can, by the end of this session, I think we should be able to answer all the queries and questions which all of us have here. So whenever we are seeing any open fracture, any contaminated fracture, the goals of the treatment is to convert an open fracture into a closed, non-infected fracture. So whenever there's an open fracture, which we mean is a grade 3B plus fracture, we have to consider that as an infected fracture. And the aim of our treatment should be to convert it into a closed fracture, a non-infected fracture. That means the soft tissue envelope over the fracture should be neat and clean, so that the further subsequent fixation is feasible. So converting an open fracture into a closed non-infected fracture is the goal of the treatment. And if we achieve that, and I think we are good to go. So negative pressure wound therapy or vacuum assisted closure, it has definitely revolutionized the current wound management. It is used in acute as well as chronic wounds. So if time permits, we'll show cases in which the V.A.C. therapy or the negative pressure wound therapy is used in chronic infected wounds as well. So compound fractures are, along with the extensive soft tissue loss, is always a challenge for every orthopedic surgeon to treat. There are multiple surgeries, plastic surgeries, and cost is always an issue, especially in Indian scenario. And the aim is to cover the exposed bone. That is the primary aim. Like Dr. Vikas Agashe had said, that there should be a good soft tissue envelope around the bone. And finally, we have to achieve the union as well. That is also, it's not just we have to make it a closed wound. We simultaneously have to work to achieve union in that particular area. I would like to make this statement in the beginning, right in the beginning, that negative pressure wound therapy is not an alternative for debridement. So sometimes when we see some patients, old patients, a week old, 10 days old, maybe some weeks old, with infected wounds, and just applying a negative pressure wound therapy on those wounds is not a really good idea, because debridement is the essential key. Removing all the dead necrotic tissue, all the dead bones, sequestrum, whatever is there, is the primary treatment for that point. And then you can add a negative pressure wound therapy to optimize facilitate healing of the wound, to have some granulation tissue over that. So coming to that, I will quickly tell the mechanism, how it works. There are basically, it's really a simple mechanism which has been tried and tested, published in many journals, which they call it as a macro strain and a micro strain. A macro strain is something like a mechanical closure of the wound. What happens basically is when there's a negative pressure, this draws the wound edges together and removes the infectious material simultaneously. It reduces the edema and it promotes the perfusion. So by that mechanism, the size of the wound basically reduces. So that is one way how it reduces the size of the wound. And microstrain, which is more importantly, which has been tested in vitro, that studies have shown that there is a stretch, there is a cell stretch under a negative pressure, which stimulates the cellular activity that results in granulation tissue formation. And we have seen that when we apply negative pressure wound therapy, there is a very good healthy granulation tissue which is formed if it is appropriately put on a particular patient. And in vitro, in vivo studies have shown that the foam contact with the tissue under negative pressure creates tissue micro deformation that leads to cellular stretch. So that it works at the basic level, which is a mechanical level, which reduces the size of the wound, and also at the cellular level, which helps in promoting the perfusion as well as increasing the cellular activity, and which leads to formation of the granulation tissue. So that is basic principle how it works. So as this slide demonstrates that there is a closure of the wound, there is a reduction in the size of the wound when a negative pressure wound therapy is applied, because the dressing stabilizes the wound and pulls the wound edges together. And this helps to decrease the edema in the peri-wound and the size of the defect, and the body has to fill. So that is how the macro strain works. And it can be used in acute and chronic wounds. Acute like traumatic or burns on flaps or grafts. Chronic like diabetic ulcers, pressure injuries, venous insufficiency ulcers, or subacute like dehisced wounds, or sometimes infected surgical site infections. Like maybe it's an internal fixation or for any fracture or any total joint arthroplasty, etc., etc. So the indications have very widely been spread now. So coming on to this particular topic, I'll be talking on negative pressure in open fractures. So we'll discuss maybe a couple of cases of each of open fractures and degloving injuries, and we can have some discussion with that. So whenever we see an open fracture, I think these are the 5 important points which we need to see, evaluate, address, and start our thought process after evaluating all these things. So whenever we see an open fracture, always also we simultaneously we have to see what is the degree of contamination, how badly contaminated the wound is, whether there is periosteal stripping or not, what is the time since arrival, how long has the injury been, and what are the associated injuries. Maybe most of the times they are polytrauma patients, which can be some head injury, abdominal injury. And the treatment plan may slightly change according to that. And what are the comorbid conditions? We all know that diabetes and other systemic illnesses have pretty much effect on the ultimate healing of that particular patient. So let's go to one case example. This is a 70-year-old male, crush injury, like it was a runover injury, and he's a diabetic and a lower third tibia fracture. So you can see in this image that this whole flap has been kind of degloved from the medial surface of the tibia, which is again a problematic surface because it is not covered well with the muscles. This has been this is out, and there is some periosteal stripping here. So that is how it looked at on the presentation. And this is an X-ray. You can see there's an inside-out wound. There's a segmental fibula fracture. And so the thought process at this particular time is he's an elderly diabetic male. So to take him to the operation theater as early as possible to avoid any infection, to reduce the risk of any infection rather. So we decided to take him to the operation theater. The planning was to put an ankle spanning kind of an external fixator. and to stabilize the fracture site, put this thing back in. And I think a fibula plays a very vital role in such, especially a lower third tibia fibula fractures. Stabilizing a fibula helps a lot, and which did in this particular case, I'll show you in the follow-up, that we decided to put a rush nail or a tense nail inside the fibula and reduce the tibia and span it with an external fixator, and decided on table whether the flap or any other procedure is to be done for the soft tissue injury. So this this was the picture, and we decided to close this flap, not to excise it primarily, and wait and see whether it survives or not. Sometimes you are lucky, maybe it survives and you are saved from one maybe a flap surgery. And this particular wound, negative pressure wound therapy, was applied because we were expecting some kind of discharge from there. And in 1 week, you see there is some marginal necrosis of this flap. So at this particular time, again, there was a thought process which was going on, was that whether we should wait, let it completely demarcate, and then go ahead and wait for a week more, and then we decide what is to be done, or we should do something right away. And we decided, I think it is always better to aggressively treat these fractures, because if especially in a diabetic elderly males, because if deep infection sets in, that's very difficult to treat later on. So we decided to remove all this marginal necrosis which had happened. Luckily, there was a good soft tissue cover over the bone. The periosteum was not stripped, and again a V.A.C. therapy was applied over this, and we got a good granulation tissue. And then that part was just skin grafting, and not no flap was needed, and that is how it subsequently healed. I think this is at 3 to 4 months duration. The wound had completely healed, and probably this fibular nail has done a very good job. It prevented any dislocation, any subluxation of the shaft which was going on medially, and there was a very good callus formation. And clinically, after removing the fixator and everything, there was no abnormal mobility, and we decided to make him weight bear with a walker, and he had a good decent function in the ankle and the knee joint. So we could get away in this case without an internal fixation of tibia, because if you see, there is a good callus formation happening here. So I know that we all know we are not always lucky to get a union, especially in the lower third of the tibia region, because it is a region which has a less vascularity. But definitely in this particular case, we could achieve that. I think I would say that fibular nail had given a good stability, which and then further loading helped a lot. So coming to the second case, this is a young male, 3B tibia, because you can see it's like an inside out wound, and there is periosteal stripping. Definitely you can see raw bones area here, and this again, our plan was to quickly take him to the operation theater, debride it properly, explore the wound, and push this back inside, reduce it properly, and then cover the bone. So that this was so this is what happened when we reduced. We got a good alignment with the external fixator, 3 pins on the either side. This is one transverse pin, so like a delta frame. We got a reasonably good and I also spanned the ankle stability. But you can see after putting a fixator, this is the position. This is a bare bone, and this is very, very important, because a lot of times we face questions regarding whether we have to put a V.A.C. on an exposed bone. Can we put a V.A.C.? Do you expect granulation? I think the answer to that question is that if there is stripping of the periosteum, you cannot put a V.A.C. over it. See, V.A.C. has its advantages, but sometimes it can be counterproductive, and because it creates a closed environment, and you are putting it on for 3 days minimum. Sometimes maybe in our scenario, we extend it to 4 to 5 days, and you don't know what is happening inside. So if there is stripping of the periosteum, there's enough literature which suggests that the V.A.C., the negative pressure wound therapy is not a feasible option for that. If there is a periosteum well covered over that exposed bone, then you may, and people have shown good results, that there is a very good extensive granulation tissue formation with the negative pressure wound therapy. So in this particular case, it was the periosteum was exposed, and so we primarily decided to do we extended the incision proximally. This is the mid shaft level, so a soleus flap is a very good option for these injuries, this segment of tibia, the middle shaft of the tibia. So half of the soleus, that is known as a hemisoleus primary muscle flap, was elevated, and it was rotated, and then it was put over the exposed bone, and that subsequently it was grafted, and a V.A.C. Negative pressure wound therapy was applied over the so we have a lot of evidence, and we have been using negative pressure wound therapy over the flaps, over the skin grafts. I think my personal experience with this is that we get a good uptake of the skin graft. That is definitely for there, and also whatever collection is there, whatever serous discharge you expect to happen, that is all drained out, and the graft uptake is definitely better than without a negative pressure wound therapy. So on day 0, all this thing was done, and this is how it looked in 2 to 3 weeks of time. So you can see the wound is very well settled. It looks like almost like a closed fracture, and then it was converted into an interlocking nail, a regular interlocking. A closed nailing was done at 3 weeks of the injury. So sometimes we see injuries like this, a traumatic near total amputation of the ankle. So so initially in this particular case, he was a 45 years old male, and a neurovascular repair was done. Microsurgical repair of both the anterior and the posterior tibial artery was done first to get a good vascularity. And on table, we took a decision to salvage this foot, and this was how it looked after initial surgery that was done on day 0. We closed the flaps, what were torn and lacerated, expecting and waiting to know what will happen, whether he'll need any flap surgery or something. And then on the 4th day, we did again a relook, because it was oozing like anything. There was some infection, and again we were in a dilemma whether we have to do an amputation or not. And then we put a negative pressure. We excised all these flaps, which were thin, flimsy, and we you can see in this, and then put a negative pressure wound therapy, and you can see this. There is a very good granulation tissue. The foot was viable, and again we put one more session of negative pressure wound therapy. You can see the wound size also started contracting a bit, and then we put a split skin grafting over it, and that was after 2 weeks of removal, and that is after. Sorry. So then we started loading this patient. His anterior muscles were not working, tibialis anterior, and this is one recent video, and probably this patient will need an ankle foot arthrosis or an ankle fusion or something like that later on to get a better gait, but we could achieve a good wound closure and a supple soft tissue envelope around the ankle, so that his at least whatever further bony procedures are required, like ankle fusion or some tendon transfer or whatever, we have a envelope of soft tissue around it. So quickly coming on to the couple of cases of degloving injuries. So see, degloving injuries are different than compound injuries, which we see routinely. In degloving injuries, we see less of bony injuries, and the soft tissue injuries element is more. So what the thought process that should be, that we should anticipate that the soft tissue loss which is going to happen, because initially they may look very benign, but you will eventually see that the whole soft tissue envelope is getting necrotic. And also watch for sudden deterioration in the general condition, like sometimes they go into shock, sepsis. So an example is this 40-year-old male, a runover injury, a four-wheeler runover injury. You can see the amount of swelling which is circumferential in the arm. So it is expected that this whole circumferential skin loss is going to happen. So this was a side sweep injury. There was an intra-articular fracture of the distal end of the humerus with some bone loss. There was a gross ligamentous instability. The elbow was completely unstable, a degloving injury, and also he had some head injury which was pretty much stable. So this is the X-ray. You can see there is some lateral condylar fracture is there. There is some medial condyle avulsion is there. So as such, it was a grossly unstable injury. So on day one, we did a thorough debridement. We have excised all the tissue which was expected to be, we assume that it is not going to survive. And then some K-wires, couple of K-wires fixing the lateral condyle. The medial epicondyle fracture, basically, it was a medial condylar avulsion of the complete flexor tendon mass. The common flexor origin was avulsed, which was repaired with a anchor suture, and it was the neutralizing external elbow spanning external fixator was put. So this was done primarily, and a negative pressure wound therapy was applied. And this was after we changed our first negative pressure wound therapy, we saw a good granulation tissue, and we thought of quickly covering it with a skin graft, and that was grafted, and it was again a V.A.C. was put, negative pressure was put, and this is at 3 months. There was a reasonably okay function of X-ray picture, no dislocation. There is some slight subluxation seen here, but considering his injury, that was fine. We again posted him for an elbow arthrolysis. This is the day when he was posted for elbow arthrolysis. At 8 months, he had a stable elbow and he had a good function in the hand and wrist. Luckily, his radial nerve and everything survived. And then we posted him recently for an elbow arthrolysis to gain some function. He got around 110-20 degree of elbow flexion. So the second case is a 20-year-old female, again a runover injury, a degloving injury with the thigh, and she had a transverse shaft fracture of the femur. Like the previous case, I said we anticipate that this whole skin and subcutaneous tissue all is going to go. So primarily, there was a radical debridement which was done from, this is the front, back, and side view, and a V.A.C. negative pressure wound therapy is a very good option in such cases. And this was primarily fixed internally, internal fixation was done, and this is post negative pressure one session, and it was quickly again covered with a graft. And this is how it looked at 1 week. And again, this is how it looked at 4 months. So this is recently, this patient could not come for the follow-up, and that was a video sent by the patient. She had a decent range of motion. It's a full range of motion in the knee joint. You can see walking full weight bearing, minimal lurch, and a good supple soft tissue cover around the knee joint. So we could achieve that result. And the last case of degloving injury is, this was a 32-year-old male. He had a fall from a bike, and he got caught up under the wheel of a truck. So when he came to the casualty, this is how it looked. And surprisingly, he was doing his active SLR. He was bending his knee, and he had no bony injury. And when we examined, and you can see this was the amount of degloving injury. This whole skin had ripped off, but all the muscles, all the tendons, everything was intact. The patella was fine. His ankle was fine. And if you see clearly, you can see these marks. These are marks of the tire of the truck, under which it had got struck, and it kind of pinched the skin and ripped off all the skin and subcutaneous tissue. So at that point, the thought process was whether we should remove the entire skin, or should we suture it back and see what is happening? Should we take the graft from the removed skin and graft the defect, or should we graft it primarily excising the whole skin, or should we use an autologous skin graft? Can we get an adequate graft from the opposite thigh, maybe from the abdomen or back? Donor site issues will be there. Or should we use a graft from the skin bank, or should we use an external fixator or not? Because now there's no bony injury, patient is doing an active SLR. Should an external fixator be put or not? So when we see injuries like these, a lot of things come into your mind, and I think each of these issues should be addressed properly, and the decision has to be made quickly, what is to be done without wasting any time. So in this particular case, we decided to do a radical debridement. The excision of the whole skin, whatever skin was avulsed, we removed the whole skin. We decided to do an external fixator in functional position of the knee, so that our subsequent surgical procedures, skin grafting and other things becomes easy, the dressing becomes easy, and you get a good stability, and the wound healing is better with that, rather than putting a slab which usually breaks down with such injuries. And we put a negative pressure wound therapy primarily. So after 3 days, the wound started looking better. This is the iliotibial band, which was intact, but it started showing some slough, and then we had to debride it again, remove the whole thing. We want to see everything like this red. So this part was again debrided. A negative pressure wound therapy was applied till the whole thing became dry. And then on 7th day, we decided to do a skin grafting, and we took the graft. We used a harvester and a mesher in this case, and because the surface area was wide, and luckily we could get all the required graft from the opposite leg, and that is how it started looking better. The graft uptake was good, and then it went on to healing well. This is at 2 months follow-up. We started his range of motion of the knee. He was doing pretty okay for that. And this is again, recently he had sent his video. At 2 months he started walking. He had a limp. He was very happy that he sent me this video on WhatsApp, because again he could not come to follow up because of this lockdown. And gradually then he started getting good range of motion. So there is, I think, if we see literature, there is enough literature published now to see whether the duration of the open wounds, the traumatic wounds, when to put. The ideal recommendation, which all the literature suggests, is that the negative pressure wound therapy should be applied for 3 days, 2 to 3 days, and not more than that, and it should be changed every 3 days. However, sometimes, in our situation, we extend it to 4 days or 5 days, which is usually not recommended. But at 3 days, we should change it, have a relook in the wound. And there are also various advances which have happened in this, like installation V.A.C. and cleans choice wounds. Different kinds of foams are available. We'll talk about that. Dr. Agashe will talk about that subsequently in that. And I would like thank you, and I'd like to hand over to Dr. Agashe now to for further reading.
Yeah, thank you very much, Dr. Warid, for an extensive and very illustrative talk. You really covered it very well. Now let's move ahead. May I request Dr. Chandak to share his presentation, and he'll share some very challenging cases.
Good evening, everyone. Thanks for this opportunity. I would like to share some cases on use of negative pressure wound therapy. So you are able to see the screen?
Yes.
Yeah. Okay. I'm just optimizing the screen. Yeah. I'll be presenting on the use of negative pressure wound therapy in complex open injuries. Friends, whenever we have a bad compound crushed injury, and when the knife needs more help to do a complete job, negative pressure wound therapy definitely helps us in managing many facets of wound healing. So this was, oh my God, injury, a mud impregnated run over wound by a truck. And as you can see the wound, it's really difficult and challenging. This is the X-ray It looks almost radiologically completely severed foot, but the distal toes had good vascularity and the plantar skin was quite good. So in this case, our surgical goals are achieved by use of IV antibiotic, good debridement. That's the key to achieve good result. And use of negative pressure wound therapy in the most appropriate manner, stabilization with either a X-fix or minimum covered internal fixation as we used in this case, delayed or primary wound cover, and adjunctive therapies as soon as the wound allows a wound cover. In managing such mud impregnated wound, apart from a good debridement, negative pressure wound therapy, hydro debridement also is a good asset. So in this patient, the hydro debridement was carried out after macro debridement, debridement with scissors, and debridement with uh, negative pressure wound therapy was used after hydro debridement. For those who have not yet had a chance to see hydro debridement, this is what the hydro debridement tool is, where after our debridement with the scissors, so it has to be used like a paintbrush. It cleans and debrides the mud, the dead tissue, and the slough, the external layers of the wound. You don't use it on a hard bony surface. You don't use it on a vessel. You don't use it on a nerve. And it just has to be paintbrush like cleaning. You are seeing two different cases here. And this is how the hydrodebridement principle works. So this patient was managed by hydrodebridement. This patient also had compartment syndrome since this was run over by a truck injury. And after debridement and the complete compartment release, then the patient was subjected to a negative pressure wound therapy, one or two sittings of negative pressure wound therapy. And once a good tissue bed was created, the ray fixation was done with uh, multiple K wires and cross K wires. This is that debridement tool. And then a specific foot covering negative pressure wound therapy by a foot complete cover in two different sheets, and then instituting negative pressure wound therapy at a very low pressure so that the vascularity is not at stake. In the subsequent sittings, at around 3 weeks down the line, the patient was subjected to microvascular flap and a split graft over the compartment release side. The vastus lateralis base flap was used. And then once the wound responded well, patient was rested on a foam so that he doesn't develop equinus and the edema is also taken care of. And this was the final result. At around say 2 to 2.5 months, a complete good tissue healing. All the wounds had healed. There was no discharge, there was no sinuses apart from the bulky looking flap, and he was restituted to his function quite astonishingly. At around 4 to 5 months, he was back to his previous working function. Foot shortening in such a case helps a lot since the complete bone severance was there. So we resorted to foot shortening so that the bony coaptation is better, and that in such crush injuries of foot helps us to achieve reasonable function faster. This I am presenting the second case. This was a case of road traffic accident, 30 years old male, initially treated at another orthopedic facility. Debridement and X-fix application was done. This you are seeing the X-ray on day 2 of his injury. This was, he had to get back to his town and the town was quite far away and he had an injury in a different city. So in the meantime, transit, etc., he got badly infected. This is how patient came to our hospital, pouring pus, sepsis, renal failure, creatinine shooting to beyond 5, hemoglobin had dropped to 4.5, and gross rise in total count. This was the picture after first days of just wound wash and lavage and dressing, done as an emergency procedure. And as soon as he was given, was fit for anesthesia, a thorough dedicated debridement and a negative pressure wound therapy application was done. Now his renal function started improving, and with multiple transfusions, he fared better. This was after first negative pressure wound therapy. As you can see, the biggest change after instituting negative pressure wound therapy is the bed gets vascular. And with those foam reticulated foam, this bed has a robust granulation tissue, which itself leads to a good healing response from the patient. And he was also given culture-specific antibiotic. Negative pressure wound therapy dramatically brings healing response from a bad infected wound to a good wound with good granulation. This patient required a second negative pressure wound therapy after 3 days, and in the subsequent sitting, the bone ends were also debrided. A complete bone debridement was done, and almost 5 to 6 inches of bone gap was there. He was on X-fix. Initially, a split thickness graft was done, and as soon as his wound allowed a flap, he was taken up for a cross-leg flap. So a complete bone segment which was necrotic, not covered with periosteum, and which was dead. There was no paprika sign in this area. And after the renal functions completely improved, the plastic surgeon did a cross-leg flap for that area. It is useful to get a cross-leg flap, and under that masculine membrane, if you can form by antibiotic cement spacer. So this is antibiotic cement spacer. Just to keep it tucked down to the original bowl, a small K-wire, and then a cross-leg flap was given. And a cement spacer inside also helps control the infection. If required, in such patients, we can use a surface vac to reduce the edema if required. But by and large, after a flap, may not be required. This was a X-fix changed to a ring fixator with the antibiotic bone cement to provide him with a weight-bearing fixator, and which was also well tolerated by the patient. At the end of around 6 weeks, good infection control, good vascular bed, the induced membrane had formed after a cement block removal, and this large segment of bone, 5 to 6 inches, was filled up with Rimmer irrigator aspirator obtained grafts from the femur bone. This is the sludge of rear graft being packed in that whole area, and we have enough skin to take care of the complete coverage of bone. This is how it looks immediately after the procedure. The whole column looks filled up, and this was the consolidation almost after 1 year. Rear graft do take some time to consolidate over a period of time, and in the long time to consolidate, occasionally if patient develops a stress of that long segment of bone regenerated, then we can protect it with a subcutaneously inserted plate. This was the final result. Equinus was minimum, great advantage to the patient at the end. This is the third case. This patient had road traffic accident 6 months back, had a compound injury. The initial flap, graft, etc. did not do well, and he had a complete necrotic bone segment in the middle area. He was already on a X-fix. This patient, in spite of a X-fix, but the primary treatment did not involve the excision of the fragment. This is how he presented to us. Excision of that segment, X-fix was continued, shifted to the X-fix from the ring fixator, negative pressure wound therapy to get a good optimum wound bend, then a cross-leg flap and antibiotic cement spacer was done. This is the cross-leg flap. We see to it that inside the flap, there is a good spacer of cement, which is almost of the size of bone and even a bit larger, so that the subsequent bone formation in the induced membrane, we have enough space to have a good column of bone. This was the column of bone, this long segment, and some beads to take care of infection if it is there. For putting such a long segment of bone, either we go ahead with a fragment transport, or we can managed with a bone graft from the Rhea graft. This was the medullary cavity. So we take a medullary reamer in the reamer irrigator aspirator system. This was around 10 millimeters. So we took a reamer of 12 mm and obtained Rhea such graft. This is immediately after Rhea grafting. So you can see the whole column got fixed up. At the end, we had some truncation of the graft. This is how during the subsequent healing phase it is. You can see how the graft matured. Medullary cavities, you can see even at the end of around 13 to 14 months, there is no medullary cavity, but the bone has healed very well. Note that thin zone is likely to go for stress fracture. So this end of the bone should be grafted in bulk. So at this point, more graft should have been there. This was after the Rhea grafting, and this is how the patient is at the end of around 1 year, now ready for his fixator removal. So with the use of LRS, negative pressure wound therapy, and reamer irrigator aspirator, we could salvage a patient at the end. Vacuum assisted, I would be just touching upon the vacuum assisted closure mode of negative pressure wound therapy. See, the application of vacuum assisted closure mode, what we need is we want to go get the flaps as near as possible so that at the end of negative pressure wound therapy, we are able to close the wound without requirement of a flap if it is closable. If there is a lot of tissue loss, a lot of stretch on the wound, then this is not possible. So this is, we can have this mode in two types, after infection control or even after acute compound fractures. We'll see after acute compound fracture. So this was a compound fracture, both bone leg, the inside out injury. This was debrided and just low tuck subcutaneous vicryl tucking sutures were taken. And at the end, we take out small foam from the both ends of the wound. The wound is tucked up, but still not tightly closed. Then an adhesive film is applied to the adjoining skin to avoid skin maceration, a small film. And I would request the VAC company people to have some attachment in the available kit so that when we use it in the VAC mode, we can put it pasted onto the adjoining. So what I desire is a round circular film with a central hole so that that film can be pasted here. The advantage of pasting a small film here in the adjoining skin is that the skin would not get macerated. And for vacuum assisted closure mode, we close it with a film and then we make a small hole into that film. I'll show in the next film. And this is how you do it. So initial film is there onto the small foam at the end, and then a large foam sheet is kept. Foam is sealed with adhesive film. Cut a small hole. Apply suction to ensure proper seal. As soon as you can see the foam, as soon as you apply negative pressure, this foam gets shrunken, it reduces in size. The foam end is enlarged. Then we apply the sensor track, which is available with the foam kit. This is the application of sensor track, that is, and the advantage of this sensor track in the system available is it is a therapeutic regulated accurate care. So it gives the exact pressure inside the foam. That is the biggest advantage of the system. And you connect the tubings. Once the tubing is connected, you adjust the pressure and have a seal check. So it should remain in the green zone and apply a pressure of, on day one in compound fractures, I usually keep 25 millimeter pressure. And on subsequent day, when the risk of hemorrhage goes down, then you can increase to appropriately 75 or 100. How much pressure to apply? See, when you have an uncompressed state of foam, almost 95% volume is void. But when fully compressed, say at around 100 to 125, 80% is shrunken, the foam compresses. So have an appropriate foam pressure. I would give mic to Dr. Agashe, sir, after presenting
Thank you very
these two
much.
cases for further talks.
Yeah.
Thank you, sir, for
Thank
this.
you very much,
opportunity.
Dr. Chandak, for great cases. Now let's go ahead. Yeah, is my screen visible now?
Yes.
Yeah. So I'll be discussing some new developments.
So you are probably muted, not able to hear your voice.
Is it?
No,
I
it is
don't-
audible. It is
Yeah,
audible.
yeah, audible. Now audible.
So I'll discuss some new developments, some challenging situations, followed by pitfalls. At the outset, I must sincerely thank, we call them gang of plastic surgeons and orthopedic surgeons. There are two main developments that have occurred in negative pressure therapy. One is V.A.C. Veraflo or V.A.C. NPWT that is instill, and V.A.C. Veraflo cleanse. I'll start with an example. This gentleman around 60ish presented in a toxic state a week after fall from height on both feet. You can see there are wounds on both sides, a very foul smelling infected wounds with necrotic tissue, and you can see the bony injury. There's a subtalar dislocation, comminuted fracture of the calcaneum, comminuted fracture cuboid, and this is on the right side, which is a less severe injury. And on the left side, there is a talonavicular dislocation, there's a comminuted fracture calcaneum, and there's a subtalar dislocation, plus fracture cuboid, and a plantar wound, which is considered to be really troublesome. In addition to that, he had diabetes, hypertension, liver cirrhosis following chronic alcoholism, and no debridement was done for 7 days as he was on ventilator. Therefore, this is a limb and life-threatening condition. In this case, we felt that the debridement may not be really thorough, and obviously there would be very high chances of infection. So can we reduce the risk of infection by mechanical means? Can we just keep washing the wound and then keep sucking, washing and sucking? Now, what actually would happen with this irrigation and suction? This would not allow the liquid to remain on the wound. It will reach only the superficial areas. On the other hand, if you soak the wound, instill normal saline or some solution, the liquid would remain in the wound before being sucked or drained, and this would reach deeper wound areas. So in short, you can have instill and then create suction. So the NPWT works on this principle: installation of appropriate topical antimicrobial or plain saline, followed by vacuum or removal of infected material. Removal of infected material is vitally important. So that's the new machine which can be used as a standard NPWT or a V.A.C. Veraflo or V.A.C. Veraflo instill. So there are two phases. First phase is instill phase or dual phase, which cleanses the wound, dilutes and solubilizes infectious material and wound debris, and then there's a suction phase. Now, we are all used to using intermittent suction, where there is suction for some time, there is no suction for some time. Now, in this case, since we are instilling fluid, you can't keep sucking and leaving, because that seal would go away, and therefore only continuous suction is used. And there are various ways in which it can be used, and there are a number of papers which have shown that the granulation thickness, tissue thickness, is much better with instill therapy. The granulation tissue also is much better with instill therapy. Question is, what is the timeline? How do you time this? So what has been generally proved is a 6-minute or 10 minutes or 5 minutes or short period of time for installation and longer period for vacuum. So 6 minutes instill, 3 hours suction is generally used. So this is considered to be better. There are various solutions that can be used. All in all, normal saline or what is called polyhexanide are quite good. So in this case, our first step, of course, was a very aggressive debridement. Now, since he had multiple fractures and pretty bad wound, I was, as I said, really worried about that. So our first step was explore, debride, reduce, stabilize, and then apply VAC. So here you can see we took hold into the talus. That's post debridement. Obviously, this wound needs reconditioning or optimization. And this is on the left side. We reduced, use K-wires for reduction and stabilization. And this is on the right side, that's on the left side. The culture-specific antibiotics were given. And this, you can see, over a period of time, significant improvement in the wound, and we could put a split thickness graft. That is on the left side. You can see a superb development of granulation tissue, and then we could close this. So this is him. He sent this video. We had never dreamt that we will be able to salvage both the limbs, being a compound fracture presented after a week in very, very badly situated, badly infected condition. So our protocol generally is, if the foam is very large, we use 30 ml. And if the foam is small or it's a small wound, we use 6 ml of instilled volume for 10 minutes. And for 4 hours, we use continuous suction. That's pretty useful in comminuted fractures whenever there are cavities and late presentations. Prontosan is a pretty good instilled solution. However, it produces little pale granulation tissue. So when you are about to do a skin graft, it is better to use saline solution. Now, Dr. Warid, if you could discuss, I'll stop sharing, and if you could discuss about VAC or negative pressure in infected situation.
So shall we discuss that salvage plate first, or we'll discuss the infected, the radius salvage?
Radius plate.
Yeah, that we discuss.
That case you can discuss.
Okay, thank you, Dr. Agashe again. So many a times in our practice, we see surgical site infection. Surgical site infection, all of us know, is that we have done any kind of a surgery, probably an internal fixation for any fracture, and there is an infection. It is a big problem, and it can give all of us sleepless nights. We all know that. So we do often come across patients recently operated, they have infection, and there is always a dilemma whether to debride or to not debride, also to retain the implant or not to retain the implant. Because if it is our old patient, it's my personal observation, we try to be on the conservative side, and maybe we start with some antibiotics, higher antibiotics, and refrain from doing any other surgery in the recent time. And again, we have seen a negative pressure wound therapy is a good tool in this situation if it is properly a proper chosen indicated patient is there. So I'll share one case. I think there's a lot of learning in this case. This was a 40-year-old male, a compound fracture. It was a grade 1 compound fracture of the radius. I don't have the initial X-ray, was operated elsewhere, and it was a plating was done. So the initial thought process, I saw this patient, and then this is the wound condition. There's like a deep cavity. There's pouring kind of a pus, not actually pus, but a lot of serous discharge, and it looks to be a bad granulation tissue over this. So definitely looking at the X-ray, it looks fine, but looking at the wound, it was definitely not great. So this is at 1 month post initial surgery. So looking at this X-ray again, retrospectively, if we try to see what had happened initially, if there was a radial shaft fracture for which a radial plate probably was planned, this particular surgeon has put it on the radial surface. Maybe there is never a need of two plates at a radial shaft area. So probably there was an hydrogenic fracture of the metaphyseal region for which the Ellis kind of a plate LCP was put. So basically, two plates are put on in one area, again, leading to maybe more devitalization of the soft tissues, stretching, retracting while doing the surgery. And again, that may be one of the cause of infection, but whatever that causes, but the situation presently is this. So the thought process again at this particular time was definitely we have to go down and debride, and whether we need to retain those implants or we need to remove those implants, that was a big question. So removing all those implants was a bit, I was in a bit of dilemma, because at 1 month, if you are removing an implant, you definitely are not expecting any kind of union too soon, and making it unstable will again aggravate the infection, because all of us know that if it is unstable, the infection is not going to settle. So we decided to open it up, and this is how it looked intraoperatively. So there was a dirty granulation tissue all around the implants, and this is the volar plate, and this is the plate which is applied on the radial side. And once we went down there, and there we could salvage one plate. We just removed one plate. There was one sequestrated bone which was in there, and probably which was one of the focus of infection, because it looked classically like a sequestrum with one side rough and one side was smooth, and it was lying kind of free. And that time we put an internal fixation. We put a negative pressure wound therapy because we retained one plate, because that helped in maintaining some sort of stability. And this is that radial sided plate for the shaft fracture was removed, and this was maintained intraoperatively. A couple of screws were loose proximally, which were tightened again, locked again, and retained that plate so that we could get some structural stability in there. And we did loose closure and did not close it, because otherwise the situation would probably we'd land up again in the situation like day one it presented to us. And with this situation, we put on a negative pressure wound therapy, and we could see this is after 2 weeks, and there was a very good granulation tissue, like it was a deep cavity earlier. It got filled up, like we saw in Agashe sir's case, also in the talus. So again, it is a very good tool, especially when we put it on an intermittent pressure and not in the continuous pressure. When we are putting it over the cavities, there is a very good healthy granulation tissue formation, and we put a graft over it, and that is how it looked after 3 to 4 months. Absolutely fine. The fracture healed, the wound healed, very good hand function, and there is no need of removal of the other plate as well, because the infection settled down pretty decently. So thank you. I just wanted to share this particular case, and we can maybe, sir, we can have some discussion on this, or we can continue to have the discussion later.
Yeah, Dr. Chandak, you have any suggestions, comments, questions? I mean, I'm amazed that you could keep one plate and salvage it.
Absolutely.
How did you take that decision of keeping one plate?
See, I think, sir, intraoperatively, we definitely found out both the plates were loose. One plate was completely loose, there was no point of keeping that. We removed that, but the other couple of screws were loose. But the fracture was completely visible. There was no sign of healing at all. So I think removing that would have maybe created a lot of problem in terms of settling the infection only, because that mobility, macro motion and all those things would have aggravated the infection maybe, and he would definitely had landed up, later on we had to do some internal fixation and bone grafting again which so I think negative pressure wound therapy definitely curtailed all those things, and we could reduce all that time and
Right.
recovered it pretty well.
Dr. Chandak, you have any suggestions? Otherwise, you can go ahead with your presentation on infection.
You're on mute, sir. Dr. Chandak, you're on mute.
I would like to ask a question.
Yes, sir.
Do you use V.A.C., negative pressure wound therapy, with antibiotic loaded beads or cement spacer as well?
Yeah, we have used in lower limbs, probably. I think in a couple of cases which I remember, when there was a lower third femur shaft fracture, I think when there is a lot of good soft tissue envelope in which the beads are very well incorporated inside, that times a couple of times we have used it with that also.
Okay, and then you
Yes.
put V.A.C. onto intermittent mode or a continuous mode when you use beads?
Sir, when we are using it over the cavities where we expect a granulation tissue formation to happen, I think that time we put it on an intermittent mode.
Okay.
When it is like over loose sutures, when closure is not a problem, when we can achieve a closure, but there is a lot of copious discharge, serious discharge is coming, that time it is continuous.
Continuous. Okay.
Yes.
Thank you so much. Thank you.
Thank you.
Thank you.
Yeah. Dr. Chandak, would you
Yeah.
like to
Yeah.
show your cases?
Yeah. So I'm just trying to share this screen.
Sure.
Yeah, just a moment. So presenting this patient, you're able to see the screen, sir?
Yes.
Yeah. So this was a 60 years old man who had a self-skate from his vehicle, had a closed injury, fractured tibial condyle, and he was in a peripheral township and was operated on day 2 after his tibial condyle comminuted fracture. Was operated at another facility, and this was the internal fixation done initially. And post-operatively, as I inquired from the patient, he had a lot of pain, a lot of swelling, a lot of edema, persistent nagging pain, and a lot of neuralgic pain in the leg as well. And at around almost he had multiple IV injections, a lot of painkillers, etc. 2-3 months he was continuously in discomfort and was left with at around 3 to 4 months down the line with this scenario. So this was discharging pus from the proximal end of the plate. Patient was not able to move his knee and from the distal end of the plate. So this was the clinical scenario. So would you like to suggest some modality of management at this point? Warid or sir, if you would like to say something, or should I present the case?
Yeah, I think you can present it.
Okay. So this, since there was continuous pus discharge, no response to healing, we had implant removed. He was taken up for implant removal and a thorough debridement. So whenever there is an infected case and a picture like this, though it looks a problem here, and he had 2, 3, 4 debridements at the same initial place, but he did not respond. Again, he used to fill up with pus. So we had a complete wound exposure made, debrided complete thing, removed the antibiotic film, granulation tissue, everything, and all the dead necrotic muscle of the anterior compartment, which were not functional, whitish and deep, thick fibrous tissue, that was removed. And then this is how it looks during the debridement. All these drill holes, everything had pus inside. So those were finely curated out. So wash, lavage, copious lavage intraoperatively, all the holes. And we need a very small angled curate to go into these holes. Otherwise, we are not able to debride those. Or we can take a thick needle and then scratch with that. The best is a bit angled, very small cup curate. And once the whole debridement was done, Then also he was put on a negative pressure wound therapy, and during the same period, to give stability as an X-fix, I had used extracutaneous plate. This was how it looked intraoperatively, and all everything. There was a huge cavity in the proximal screws, and that was removed. This, you can see, whole cavity was there. So he had all deep-seated infection, so that was removed. Wound was curated, and then a vacuum-assisted closure mode was the foam was used. What we do in this is the whole foam is inside the wound, and then the wound edges are bit approximated without tension onto the wound, but the vacuum inside and the foam shrunken with vacuum draws the wound edges closer. So if we master this, then the requirement for flap reduces a grade. So this is how the vacuum assisted closure mode is there. And then you, on this, you put a film, adhesive film, and then put a foam, and then give negative pressure along with the ECPO that healed very nicely. And this was managed with the negative pressure wound therapy and ECPO. As you can see, after 5 months, this articular reduction was practically not good and would have spread the infection inside. So we accepted that, whatever reduction we could get, and applied like a X-fix. This is how this wound healed after only one sitting of negative pressure wound therapy, and then gradual closure, and then in the second sitting this was closed. I kept the foam dressing for around 5 to 6 days in this patient, and that bed healed. And this is the subsequent X-ray. The patient is walking well on this, and over a period of time healed for this case. This is another case I'm presenting. 5-month-old compound fracture shaft femur, operated at another orthopedic facility, and had initially was treated in ICU for his multiple other injuries as well. The initial management was with X-fix, but with X-fix the all pins got loose, so he shifted to another hospital where he had ender's nail, flap was done, but had continued to have wound discharge. And this is the time he presented to us, badly infected. So as somebody just lifted the thigh, it used to pour pus almost into the whole bowl, used to get filled up. And this is the dressing. Just within half an hour, the whole dressing used to get soaked up. So badly infected he was, and his ender's nail were also popping out from his knee joint. This is what the picture was, and as you can see, the infected scenario, the nails popping out. He was taken up for debridement. A complete thorough debridement was done, wash, lavage was done, and as Dr. Agashe sir had suggested, for such badly infected case, instill therapy is a very good therapy. Here, the whole end of the bone did not bleed at all. So almost for 4 to 5 inches, you can see the bone ends perfused here, but the whole ivory bone, that required excision. And then again a vacuum assisted closure mode. The foam size here is lesser than the wound size. The skin edges are coapted. Lessing is also another technique to reduce the wound edges together. This is in another patient, the use of lacing. So with the staples and foam attached, you can just lace them as a bootlace technique so that the wound edges can be brought closer. So 1 or 2 or 3 therapies would allow you to close the wound. Especially in a thigh, we have enough skin to close down. In tibia, usually it requires a flap. So dead bone excised wherever it was not bleeding. After removal of the first negative pressure wound dressing, the wound looked absolutely immediately responding to the treatment. And also the proteus and the clepsula which were grown is good, required meropenem and colistin for this patient. Rest all he was not sensitive. Antibiotic spacer was also used. So that also gave a good response to the copious pus which was coming out. This was after the removal of foam, after the vacuum assisted closure mode. As you can see, the whole muscle bed, etc., the facial tissue, everything looks with good granulation. The other wound edges, the discharging sinuses from posterior aspect, from the medial aspect, from the flap side, that also got well. And this is the final wound healing. The same patient pouring pus at around 3 weeks down the line in hospital was so happy. Last 5 months, he was continuously getting dressed with a lot of pus and everything. The other sites which were grafted initially, which also started pouring pus, that also healed. So vacuum assisted closure mode with negative pressure wound therapy is an excellent way to treat wound, reduce the wound side wound bed so that we can close them. Thank you for patient listening. I would hand over to Dr. Agashe sir for the questions.
Thank you very much, Dr. Chandak,
Yeah, I'll just
for
stop share.
very challenging cases. So I'll just discuss a few things. So there has been another, I would say, very useful development, what is called cleanse foam. If you can see, this is a different type of foam which has multiple holes, pretty large holes, and that with instill works wonders. Coming to the case, this was a 63-year-old gentleman, diabetic, who presented in January of 2020. His bilateral THR was done about 1.5 years ago, 1 year, 3 months ago. On the left side, he started getting pain 3 months down the line, had a purulent discharge from that, and the surgeon had done debridement 3 times. The last surgery consisted of debridement and articulated spacer. When he presented, you can see there is a discharging sinus, significant pain. He has hardly been walking. That's the spacer, which shows displacement. The culture, which was taken a few weeks ago before he presented, had shown atypical mycobacteria or rapidly growing mycobacteria, Mycobacterium abscessus. So all in all, a very troublesome scenario. So the first step was, of course, a very aggressive debridement, removal of the spacer and very aggressive debridement. Here you can see the original incision was excised. You can't incise that incision. You have to excise that incision, excise the infected tissues. The femoral canal inside is completely filled with pus. The bone is absolutely necrotic. And the first step is, of course, a real good debridement. So inside was bleeding well, but from outside, the bone was devoid of any covering. Femur was absolutely bare. So as the relatives were not keen on replacing and they had opted for fusion, we put an external fixator, docked the bone, but every visit to OT, the bone appeared clean but absolutely bare. So I was really getting frustrated. I was wondering how we can improve this wound. And when the company man said, "Sir, we have a new system. This would be useful." So that's the foam we started using. And within no time, we had a pretty good covering of the bone, good granulation tissue on the bone. And we did a flap, a gastrocnemius flap with skin. That's the flap. And this is at 6 months. We removed the fixator, a completely well-healed fusion. So this really played wonders. Just a word about this V.A.C. cleanse or choice dressing. This comes in contact with the skin, with the defect wound, and then it is covered by 2 foams. This is a thinner foam and this is a thicker foam. So essentially one has a foam with multiple holes, then a thin layer of 0.8 millimeter, 0.8 centimeter, and a thick cover layer of 1.6. And installation is done. So this delivers topical solution, either saline or prontosan. This solubilizes the wound debris and infectious material during the soak phase, as you can see here. And once the negative pressure cycle is activated, the granulation tissue starts forming as well shown here. And you can see an excellent granulation tissue formation after using this foam. One word of caution, it should not be put deep in deep cavities or blind areas because this foam may just break and will remain inside. So we have now three different modalities: a conventional negative pressure therapy with instillation, and negative pressure therapy with cleanse dressing. Question is, when do you use what? First and foremost, we have I'm just giving an example, open calcaneum fracture, fresh injury, minimal contamination. You have a tissue loss. You need to optimize the wound, then use a conventional negative pressure therapy. But if you have a condition like this, diabetic patient, infection following Pott's fracture, here you can see a medial malleolus in non-position, patient had diabetic neuropathy. They were really worried with this and they basically wanted to get rid of the infection. They said, even if she walks in a brace, we are fine, but we just don't want this infection because she had become really toxic. Now, if you see, I have excised the wound. A large quantity of granulation tissue was removed, infected granulation tissue was removed. Now, one has to optimize this wound. We really don't know how deep is this infection. So here we have used instill. That's the wound on day 1, and that is after instill back. This is on the medial side, that's on the lateral side, and one could see that the wound really got optimized very well. Here we did a flap, and at 4 months, and this is at 18 months, there's no wound breakdown, no infection, and very happy patient walking in air cast shoe. Lastly, coming to the cleanse, when there is significant slough, non-viable tissue, and we really need to cover it early, then cleanse would be useful. I'll illustrate it with some example. Now coming to pitfalls, friends, whenever there's any product that is introduced, initially the use starts increasing, and then as the popularity increases, most pitfalls are noted during this excessive popularity. सभी रोगों की एक ही दवा, whether it is negative pressure therapy, whether it is some other implant, कुछ भी है ये लगा दो. And that is when the popularity starts going down, basically because of overuse and pitfalls. So I'll illustrate this with a few my own pitfalls. Young patient came at 4 days, no treatment taken. You can see a complete patellar dislocation, talus out, badly infected patient, and I did very aggressive debridement. I thought I'd done a great job, but as a pretty bad culture pattern, Pseudomonas, Enterococcus, Acinetobacter, and fungus. You name the germs and they are there. And I thought, oh, I have a good wound. I started V.A.C., negative pressure therapy, sent him home. And I thought in a week's time, I'll be ready. He'll be ready for a graft. Unfortunately, every subsequent dressing at home, there would be a small bit of pus. And at 1.5 months, this photograph was sent by another surgeon from another town and said, sir, this patient still has pus there. It's 1.5 months. What are you waiting for? You must do something. So what do I do? Should I shift to that new development cleanse? This is where there would be a pitfall. One has to know that at 1 month, 1.5 months time, if there is infection, there's something wrong, grossly wrong inside. So we did an MRI. You can see that there's significant osteomyelitis. The talus is just avascular. There is no way you can salvage this dead woody talus. You can't convert whatever technology you use, you can't convert dead into alive. That dead piece had to come out. So we excised that. Within no time, the wound healed with conventional negative pressure therapy. We could do a split thickness graft. This is him at 2.5 years, walking with a stick, mild equinus, but we could salvage his leg. Another case, infected total knee replacement, one of my very early cases. This infection had persisted and it presented with gross infection. So I did a very, very aggressive debridement. The inner surfaces were debrided. And now, when I was very happy with debridement, I put foam inside, used a pressure which is advocated -125. And friends, within 15 minutes, the canister was full. Patient was in hypotension. Now, what do? Do I reduce the pressure and give pressure dressing, or I stop negative pressure and do a pressure dressing, or I explore arrest bleeding and pack the wound, or I explore arrest bleeding and dock the bone and pack? Can you unmute yourself and let me know what would you do? Dr. Chandak and Warid?
Yeah.
Yes.
So whenever there is a bleeding with a vacuum use, I would immediately stop the use of vac, explore the wound completely. If there is any bleeding source inside, that needs to be arrested. If there is no bleeding found, still I would not use the vac on that day and assess what is leading to. And of course, the bleeding parameters, the coagulation profile, etc., has to be done simultaneously.
Yeah. Any other input, Dr. Warid?
I think I will also go with option number C, explore, arrest the bleeding and pack the wound. Probably because in this case, it was around the knee joint, so maybe some of the bleeder, or maybe it is intramedullary. But I think ideal would be to explore and stop that bleeding.
Correct. So that is exactly what I thought. So we immediately explored. The bleeding essentially was from medullary cavity, which was getting sucked by the negative pressure therapy. There was no major bleeder. Right. So this is one thing one has to remember, that if a large part of medullary cavity is exposed and you put foam between there, then it is likely to suck blood, lot of blood. So what I did was explored, achieved hemostasis and docked the bone ends rather than keeping them open, because otherwise they would continue to bleed again. Didn't apply vac on that day, wound packed and the patient settled. So that's a very, very important problem that can happen. And then we could do secondary suturing after a few days and he settled. So essentially avoid applying negative pressure therapy directly on medullary cavities. You may use a contact wound layer like a burn mesh or medicated gauze piece. Certainly not on completely exposed blood vessels, anastomotic sites, organs and nerves. And of course, certainly not on necrotic tissue like I did in the first case, and malignancies and untreated osteomyelitis. I'll come to the last case. This was a young man who presented to us just a few months ago. He had sustained injury to the right elbow on 10/5, that is 10th May. There was no open wound. He noticed that he could not lift his briefcase after the fall. Pain decreased with painkillers and ice. This is the pain increased significantly. In 4 days' time, he had to go to an orthopedic surgeon because the pain had increased. Who took an X-ray which showed a neck radius fracture. So he applied Scotch cast The pain increased remarkably at night. Next day, he went back to the surgeon who univalved the slab, but still the pain was unbearable. He changed the surgeon who bivalved the fracture, the plaster, but still the pain persisted. After a few hours, the fingers became dusky. He developed diminished sensations in fingers, and the surgeon felt that this is possibly a compartment syndrome, and therefore a decision to release compartment was taken. So here he is, a 31-year-old man with no comorbidities, was planned for compartment release following possibly tight fracture plaster for a fracture neck radius. The surgeon concerned was still concerned about his parameters. His WBC count was 25,000 and his create had jumped to 1.6. So he is really very careful. This is the photograph the surgeon has shared, and you can see moment he opened, there was a significant amount of pus from inside. A huge pocket of pus, which he drained. Next day, the counts were 52,000. The culture was streptococcus, and he was started on appropriate antibiotics. The surgeon planned for redebridement and closure. This is the time when he closed again. But within 2 days, he developed very severe pain and swelling of the entire limb. Therefore, he did an MRI, which was suggestive of collection right into the axilla and extensive changes of myositis, suggestive of extensive cellulitis, fasciitis of right arm, shoulder, elbow, forearm, with fluid collections in axillary pouch as well as intramuscular collections. And that was the time when he felt that he should be shifted to an institute and therefore referred to us. So here he is when he presented on 24th May. There was a marked swelling of the forearm. That's the suturing he had done, which had to be opened. There is still a mini V.A.C. There is a swelling on the anterior chest wall. His scrotum and penis also had swollen significantly. So all this fitted into signs of septicemia, had tenderness right from chest wall to hand. His radial pulse was felt well, finger movements were okay, but essentially there was a significant swelling from chest wall, shoulder and arm. His WBC count was 28,000, and in view of very severe pain, swelling and MRI finding, we decided to explore immediately because he was really septicemic. That is at 12 o'clock at midnight on 25th May, you can see the vascular bundle there, exposed but covered with sheath. So the priorities were saving life, saving limb, control of infection, and obviously have cover, and one has to worry about the future function. So first and foremost, explore, get rid of the infection. Here, moment we opened, the brachialis was totally necrotic, totally fragmented. That's a long head of biceps, which was again totally necrotic. The medial intermuscular septum here is necrotic. We mobilized that. The long head of triceps was necrotic. The deltoid was necrotic. lateral fascia of the lateral part of the arm was necrotic. So we had to remove almost everything there. Large quantity of muscle was necrotic. So there was a significant blood loss, and we were really worried. We did not apply. We had learned from our previous case, and we had not applied. We did not apply NPWT. But his pain decreased remarkably. Pain score came down to 2/10, except the anterior chest wall. His WBC count was 43,000 next day, but he was very comfortable. So we were very happy. So after 3 days, we took him up for re-debridement, and we decided to use cleanse foam. We thought that the new technology would help us. Now the challenges would be, obviously there would be there's an extensive wound, so the chances of bleeding would be very high. So what should be the pressure? So we decided that we will not use -125. And the another challenge was, how do you protect the vascular bundle? So we used the medicated foam over the bundle, and then we used the cleanse foam after covering the wound with burn mesh as a wound contact layer. So we thought the collection in canister would be less. So that's the cleanse foam. And we decided that we'll keep pressure low, -75. That company person kept saying, sir, please, company advises -125. I said, Arey Baba, you are not an orthopedic surgeon. You don't have to manage this patient and blood loss. So we will keep at -75. The culture was Acinetobacter, resistant to all except minocycline. So it started appropriate antibiotics. Now you can see he collected lot of fluid. HB kept dropping in spite of transfusion, but he was not comfortable. Earlier, the pain score was 2/10. Now, in spite of negative pressure and debridement, his pain score was 4/6, 4/10, 6/10, not very comfortable. His counts had decreased to 14.6, but still that man was not comfortable. So this was 27th May when we applied the V.A.C. This is 31st May. Wound was a bit better, but just about bit better. I wasn't very happy. We explored the chest, noted that his pectoralis minor was completely necrotic, so we excised that. But we found the muscles to be quite edematous. Here you can see brachioradialis. There is a fluid there. And again, we had to excise some muscles. So all in all, we were not happy. Next day, when we went to see him, he said, no, I have not slept whole night. Not comfortable at all. Now what do? Should I reduce the pressure from 75 to 50? Or I re-debribe urgently, or I increase the painkillers? Any inputs?
I think re-debride, either decrease the pressure, maybe see for a day, or else re-debride. Definitely not increase the painkiller.
I think if it is not draining appropriately in a large surface area, I would increase to around 125, 150. That is what if it is not bleeding. So we can increase the pressure.
He kept on collecting large quantity. We had to change. We used to change 3 or 4 canisters every 36 hours.
But his Acinetobacter and a large surface area in this wound, I would increase the pressure to more. Yeah.
So unless there is an appropriate drainage, this thing would not work. So I started wondering, why is he uncomfortable? He's got pain. He has that edematous muscle and is rightly put by Dr. Chandak. This edematous muscle, and that means there is something wrong. So we, in the ward, of course, we increase the pressure to 125 because I suddenly remembered that company man telling me, sir, company advice is -25. Sir, company advice is -25. So you must listen to them. So I increased the pressure to -125 and within no time, patient said, sir, I am very fine. I am much better. I am much better. And rest was history, friends. You can see this is after 4 days, wound much better. So we partially closed the wound. His parameters continued to improve. WBC count 12,000. The wound had improved remarkably. Here you can see excellent granulation tissue. So we could close the wound partially and put a split thickness graft. And that is him on 19th June. And that is him on 5th July. So we could salvage only because, honestly, to be frank, we followed suggestions of the technician at the right time. So pitfall is modification of the system on your own. Be very, very careful when you modify on your own. The pressure that is to be applied has been tested in laboratories, has been tested in animals, tested in various experiments, and then decided. So let us not change at will. And you can see a fantastic result in a very, very challenging situation using wax cleanse. Any suggestions? If you have any questions, friends, scan this QR code and send us the question, or of course, you can put on chat box. So to summarize, this is a very, very useful method. However, you must use your gray cells. You must use your knife properly. You must use your medicines properly. Thank you, friends. Now, of course, we are all open for your questions. Yeah.
So, can I ask the question on behalf?
Yeah, please.
Yeah. So, how do you modulate your treatment and VAC application when X-fix is there and the pins need to be incorporated?
Yeah.
So, any specific tricks for that?
Yes. There is a solution that is used for colostomy wounds. Plugging the colostomy wounds.
Yeah.
That becomes very useful for using negative pressure in presence of external fixator.
Okay.
Now that is little difficult to remove. So first, of course, step is rolling around the adhesive to be rolled well around the shank screw so that there is no leakage. That is our first thing. In case still it continues to leak, then we use solution which is used for preventing leak in colostomy wounds.
Yeah.
I found that to be very, very useful.
The
Do you have any
coloplast.
suggestions? Coloplast. That's right.
Coloplast. No?
That's
No, same thing we also use, but any other advanced or any other specific film adhesives or something, some advancement?
I
Yeah.
I think they have come up with some paste kind of a material, the company people, which is very effective, and that they regularly use around we regularly use that around the fixators. So it's like a paste form. So wherever there's an external fixator pin, of course, after wrapping it nicely with the adhesive first, and then they apply that, and that also helps a lot.
That is what I'm saying, coloplast. That is essentially, yeah, that's an extended use of coloplast.
Yeah. And what is your experience of using, sometimes because of the economic compulsions, we have extended the use beyond 5 days. What is your experience if you use it beyond 5 or 7 days?
I'm honestly, I used to think that it won't matter till I really burnt my fingers in one case. He had very good granulation tissue formation, and I used it for 7 days. And the granulation tissue actually penetrated into the foam, and it was absolutely very difficult to take out that foam. All the foam had, the granulation tissue had grown into the foam. I had to use actually a knife to excise that. That's very, very difficult. So it basically depends on the type of wound. If the wound is very good, it is vascular, there is no point in continuing beyond 3 or 4 days.
Okay, fine.
Very dangerous.
Yeah. Warid, any experience of using in varicose veins and getting a good granulation?
Yeah,
Varicose ulcer, the venous
varicose
ulcer.
ulcers, yeah. We have used in couple of cases in varicose ulcers. Typically, they are over the medial malleolus and anterior shin of the tibia. They do help, but I think for varicose veins per se, it is better to stripping of the vein unless we treat that tortuous veins. We clamp it proximally or we just excise, strip the vein. The ulcers don't heal. They are very high chances of recurrence. But if there are large ulcers, varicose ulcers, we have used and grafted them very successfully.
Okay. And any innovative use of negative pressure wound therapy in a recalcitrant sinus, if you have used anything?
I would consider recalcitrant sinus as a showroom. The go down is somewhere else.
So explore widely.
Unless you explore, go down and take out everything, the sinus would not heal, is what I would consider.
Right.
I think Warid, you can show a case of tendo Achilles where there's a small discharging sinus, and then
I will show that.
You can share that case. Yeah. If we have another 10 minutes, so
yes,
he can show that. Then I'll show a case of fortwin induced contractures.
Yes,
if time permits.
Okay, so all right. So friends, as we are discussing V.A.C. in open wounds, traumatic wounds, mostly in this webinar, but we definitely, the negative pressure V.A.C. therapy has a very, very important role in chronic infected wounds as well. So I would like to share this case. I think most of us orthopedic surgeons must have come across this picture. A tendo Achilles rupture, specifically a chronic rupture which has been operated. The tendo Achilles has been repaired or augmented, or whatever surgery reconstruction has been done, and there is an infection. This is pretty common scenario which we see, and this was a particular patient, a 60-year-old male, which was operated 10 months back, and a very bad chronic foul smelling discharge since the day of surgery. And when we see at this picture, there are bad skin changes, which tells us the chronicity of the infection. The ethibond sutures, which is commonly used, is visible. We have stopped using ethibond for a long time now for these particular injuries. So once this was we decided to do an MRI, and then just to find out the depth of the infection. However, maybe it's not actually required, because we know there's an infection and you have to thoroughly debride it. And intraoperatively, we could see that there was an integrity of the tendo Achilles was there. There was a very bad granulation tissue. Lot of it was excised, and partially there was some tear, some flimsy continuity was there. And I think, the meticulous debridement, all of us know, is the key in any case for that matter. And that's what we did. We did a thorough debridement, and then we applied a negative pressure wound therapy. So after debridement, literally there was a big defect which had. So this is how it looked after 2 sessions of the negative pressure wound therapy for 3-4 days each. And now this is the position. the bad skin had to be excised. If we see the first picture, there was no point of just debriding inside because the whole skin subcutaneous tissue was also involved with multiple sinuses. So all of that was excised, and then this had to be covered now. And we decided to do a superiorly based fasciocutaneous flap. So the flap was raised and it was covered. The defect was covered, maintaining the integrity of the tendon, and this raw area was split skin grafted. And this is how it looked. And the graft was taken from the calf region, and that is this is how it healed well. The patient was very happy. The patient was absolutely sad with the initial infection, and she was very irritated with 10 months of infection draining sinuses. And we could luckily get a good cover, get a decent function in the ankle. And so in that case, this really helped in that case. I think, sir, you can share one of your case, if then I can share more if there is time.
Warid, if may, by the time, if I can ask.
Yes, sir. Yes, sir.
Yeah. What do you think is the biggest advantage of V.A.C. in the healing? What helps the biggest? Is it the vascularity at the wound bed, or is it removal of the dirty fluid, or the infectious material, or reduction of edema?
Yeah. I think it does not have a major role in reducing the infection as such, because we have also burnt our fingers in quite a bit of cases, in which it did not help at all. And the reason was that there was some dead necrotic tissue inside. I think the key is to do a radical debridement, and it will just optimize the wound, definitely not reduce. But definitely one thing it helps is it forms an excellent granulation tissue.
Yes.
It forms an excellent tissue. It has definitely reduced large number of flap surgeries, and maybe skin grafts are done.
Yes.
Yeah.
Okay.
Yes.
Agashe sir is presenting.
Yeah. So when you are dealing with open fractures, generally the surrounding tissues are good, but sometimes the surrounding tissues in some situations are very, very bad. Like this man presented with abscesses both thighs over 4 years duration, and you can see there are multiple sinuses. And the history goes like this: he's chronic alcoholic for 30 years, had acute pancreatitis 20 years ago, and he became a Fortwin addict or pentazocine addict. I used to take 5 to 8 intramuscular injections for 10 years. He developed severe contractures of both hips and knees, could either stand and walk or lie down. He could not sit. There were no movements in hip and knees, and developed these abscesses. And over a period of previous 4 years prior to, he presented. Drainage and antibiotic treatment elsewhere had failed. Multiple treatments were taken. So essentially, it is a pentazocine abuse. It's a woody induration of muscles with secondary contractures, extensive fibrosis of skin and muscles, and granulomatous inflammation is also well known. Here you can see these are the normal muscles and these are the fibrotic muscles after pentazocine. And in general, it was a challenging case. He had diabetes, acute pancreatitis, alcohol, and muscle contractures. So I could take up this case only because I had confidence in negative pressure therapy. So we decided to do extensive excision and graft. And what revealed was terrible. You can see not only there was fibrotic material, there was caseous material inside. Absolutely caseous material, and he grew coagulase negative staphylococci, Proteus, Klebsiella, and MTB. He grew everything under the roof. This post exploration, you can see absolutely fibrotic muscles. This is after 6 negative pressure therapy. Things were just not improving. Absolutely fibrotic tissue. At 1 year, he healed. He healed at 1 year, and we published this as multiple abscess and myofibrosis following pentosesame abuse. And then we were in for a very rude surprise. After we published this, he again came back with a new lesion and then again kept on developing newer and newer lesions. And every time we would explore, get very bad tissues, we will use negative pressure. So the generation of granulation tissue is very, very challenging in this situation. 9th Jan, 10th Feb, by 15th March, 4th March, we think, yes, now we are winning. And 1st April, wound healed. Fortunately, after all this, things healed, and this is at 5 years, there has been no recurrence. So the tissues basically were very bad, but then improved with, or the wound was, improved significantly using negative pressure therapy. So this was invaluable whenever you are addressing this. I think it's almost 10 o'clock now. So if there are no questions, I think we can.
What is what is your experience about the change of bacteriology under a vacuum treatment? Any studies you had a chance to?
Especially in open fractures, if you use it for a long time, beyond 1 or 2 weeks, chances of infection are high. Patients who have comorbidities and you use it extensively, then chances of infection, secondary infection, are high. So one has to have a timeline that after so many days, after every subsequent change, if the wound is not improving, that means there is something wrong inside. You need to be more aggressive as far as debridement is concerned and closure is concerned. There has to be some timeline that you have to have wound cover in this much time.
Warid, if I ask you a question,
yes.
You can go ahead first.
Yeah, I have one question for both of you. What is your experience of putting a negative pressure on the amputation stumps? I mean, when there are fresh traumatic amputations, in which sometimes we think of not closing the wound primarily, keeping it open. And do you use apply V.A.C. therapy?
Yeah. Excellent, my experiences. I had used in only 2 stumps, but excellent healing. Excellent.
Right.
Yeah. Helps quite a bit. Yes.
Yeah. My question to you, Warid, is on a split thickness graft, what is recommended to use a white foam? But I have been using mostly the granular foam.
Yeah.
So your experience, you use more of white foam or?
No. We are using regular foam.
Is it available?
Yeah, the white foam was available, but intermittently. I don't know currently whether it is available or not. But the advantage with white foam was it doesn't stick to the thing.
We are using an interface, a normal Bactigrass or a paraffin gauze and a regular granular foam. No. Not a white foam. But I think it has excellent results, especially in axilla or back of the knee, bed sores. Sometimes when there is pressure is over that. We are grafting and we are expecting there will be pressure over that area. So I think it helps in uptake.
And an update from Deepika, it is available.
Okay.
It is available. So
and one delegate has asked me on my cell number, how do you economize on use of foams from the dressings?
So that company people can answer.
So that was a question from one of the medical colleges.
Yes.
Yeah. So it's a challenge for them.
Correct.
I think, and the whole technology and how they make it but that the granular foam, that is, if we replace it with a regular foam, because in many medical colleges they are using some regular kind of a foam, but that is not recommended actually. That's what.
Correct. Correct.
So I think it was an excellent discussion, sir. You
Absolutely excellent.
Yeah, excellent discussion. We really gained a lot of information.
Thank you all for.
Deepika, Deepika, any questions? If you are forwarding, we'll take it up.
So I have forwarded already.
Okay.
Yeah, it was there. It was there.
Yeah.
Okay. Thank you. Then I think we'll call it a day. Thank you very much. And
so only one question
yes.
remained unanswered. That was, what are the installation solutions that you recommend for treating infected trauma wounds with V.A.C. Veraflo Therapy? And which dressing do you prefer for the same Veraflo or Veraflo Clean's choice? What are the installation solutions? So as I think you had already answered, Fontan is what you recommend.
Prontosan and normal saline.
Yeah.
Normal saline.
Yeah. And we had already answered the dressing technique do you use for wounds with external fixator and Elizaro ring fixators. That was already at hand. Yeah. So these were the two questions which remained unanswered. We have answered them. Thank you so much.
Yeah. Thank you all.
Anyone who wants to answer question, and they can unmute themselves. If they have still any pending question, you can connect. Ashish or Dr. Mayur, Dr. Nitesh Singh, if some questions are there, you can ask. I think all the questions are answered. Thank you so much, Deepika, for this opportunity.
Thank you all for very enlightening discussion. And thank you, OrthoTv, and thank you, 3M and KCI for this opportunity. Thank you all.
Thank you.
Thank you so much, sir.
Thank you. Bye. Shall we leave?
Are we offline now?
Thank you, sir.